All right, Dr. Matt Ho, I have been really meaning to do this episode for a long time. It's funny, I've actually not really done the men's health topic justice yet. And so I picture that today we can talk a little bit about what patients would expect from seeing a urologist. And then we'll follow this episode up with what they might expect to see at a physio appointment, because I know that that is a really common thing that urologists refer to as physio. And so I appreciate your time. I know you have a busy schedule. And I have to tell you, I've not told you this before, but all of your patients that come over have such wonderful things to say about you. They really appreciate the time you spend and the care you spend to their conditions. And so you've been a welcome addition to our community here in Kelowna.
Well, thanks so much, Mel. That's really kind of you to say. I really appreciate that. And thanks for having me on to talk about this. I think it's a really important topic, and I think that men's health traditionally, you know, men tend to neglect their health a bit more than women do often. So I think it's really important that we address these things. I think especially because pelvic floor health has more generally been associated with more of a female problem, but I think that a lot of the time the same issues can affect men, and so I think it's important to raise awareness about that.
So will you introduce yourself to the listeners here? So you're obviously based in Kelowna, and actually, like, is your primary patient population male? Like, I know you'll see some female, I think you will, but I'm curious to know, just tell everybody listening a little bit about yourself before we get into the topic.
Yeah, totally. So my name is Matthew Ho. I grew up in Vancouver. Um, I did my residency in urology and my medical school in Vancouver. And then I spent 2 years in Chicago specializing in urologic cancers. And so that's actually my niche is cancer care. But I take care of patients with all sorts of urologic issues here in Kelowna. And I would say probably 65% of my practice is male, just because um, a lot of the cancer issues are primarily ones that affect males. But a lot of my general urology practice is, I would say, 50-50. Um, and yeah, no, I'm happy to be here in Kelowna. I've really been settling in. People have been fantastic.
That's great. So I always like to kind of set the stage here as to why we're discussing this. And really want to tailor this to patients. So I picture the majority of people that come here and sit. I'm in my office right now, so I point to the chair and say, the people that sit here, I so often send them home with these episodes as a way to enhance their learning. And so what I'm commonly seeing with a lot of the male clients is that they're referred by a urologist or maybe their family doctor or Google. Lately they'll start researching themselves what they can do for their symptoms, and they end up at a physio appointment. And so in the case of those that have come from a urologist, please correct me if I'm saying anything wrong here, but quite often they have an issue that's affecting their quality of life, which we'll get into. They go see their family doctor. Their family doctor would be the one that sends a referral to a urologist. I'm curious to know on average how long these people wait to see someone like yourself. And then I'm also curious to know, once they show up, or once your office assistant organizes their appointment, I just want you to paint a picture of what that looks like. What does that process look like for people, and what can they expect when they come to see you for that first appointment?
Totally. So in terms of wait lists, wait times, it really does depend. We triage every referral we get based on how urgent we think it is. So it could be anywhere from a couple of weeks to a month if it seems like something that's really urgent that needs to be addressed and can't wait. But a lot of the time for sort of long-term things that are bothersome but not emergencies, you're unfortunately looking at somewhere in the neighborhood of 2 to 4 to even as much as 6 months out. And that's unfortunately just a result of how the population here has changed, and really unfortunately how the healthcare system really is struggling with resources at the moment. But that's unfortunately the nature of things. But yeah, so generally patients can expect to wait several months to be seen for this. So uh, let's imagine the day of the appointment has come, and you've received your booking and you come into my office. Oftentimes I ask my receptionist to send a couple surveys out, symptom scores for patients to fill out, so I have a better idea of what exactly they're experiencing and how severe it is, how much it's bothering them. And having that information beforehand allows me to focus more on the solutions as opposed to just information gathering, because unfortunately our time is generally pretty limited because of the number of patients who we have to see. Um, Often I'll ask some follow-up questions, specifically tailored at the symptoms that a patient's having, and then I may not ask them to do some urine tests or some blood tests beforehand, so I get a better idea of the background, so that hopefully we can spend all of our time figuring out exactly what's going on and not have to have multiple repeat visits. Um, I'll ask a bunch of questions that we call that the history, taking the history. I'll do a physical examination. Sometimes in males, a digital rectal examination. That's putting a finger into the rectum to feel the pelvic floor musculature, feeling the size of the prostate. I do that in the office. The female pelvic examination generally, because it's a bit more involved, I tend not to do in my office. And usually at the end of the visit, we come up with a plan for how to move forward, whether that's further investigations, more scans or tests. Sometimes I suggest something called a cystoscopy, which is a diagnostic study where you come into the hospital and I examine the inside of the bladder with a thin, flexible scope under a local anesthetic. Sometimes that's indicated, sometimes not. Sometimes I can order an ultrasound or another type of scan, and then usually we set plans for either treatment or another follow-up to see how things are going.
And so I think like it just when you say that and how, people have to wait a long time and your time is limited. Actually, is that actually a set time? Because I know it often depends on kind of what MSP allows, but is there a set appointment time for people?
No,
No.
there's no set appointment time. Generally, I think we try to keep it as brief as necessary, which is kind of a shame because I actually really enjoy chatting with my patients and getting to know them. But um, when there's a wait list that's 6 months long, it's hard to do that sometimes. So I try my best to be personable and to get the full story, but also to keep it sort of limited to the necessary information. But to answer your question, no, there's no set time, and I always try to take as much time as needed to get all the information that I need, and to provide the patient with all the information that they need to go forward. Um, and so some patients that's only a few minutes, and some patients it's more like 10 to 15, depending on the complexity of the issue at hand.
So overall, they come the first time, you've already gathered some information before they get to you. You kind of go over some of those, let's say, questionnaires or scores that they've provided for you. You do your exam, ask your history, but then from there, the tests wouldn't be done like the cystoscopy or the urine test or the blood work. They would have to go and have that after before they follow up with you.
That's right.
So I'll tell you some of the main things that I think that you see, and please add any of the conditions that I have forgotten. And obviously, we're not going to be able to cover everything, but these are the ones that I think from the people that I see that you would be seeing most often. And so I'm just curious, obviously, we can't speak to everyone specifically, but if you just give an idea of some of the symptoms that people come in with and maybe picture for them if this is a symptom that they experience, what they can expect. So I think one would be when I see a lot of referrals for is overactive bladder. So
Hmm.
someone comes in describing some of these symptoms to you. Can you just give an idea of what someone like that might expect?
Certainly. So overactive bladder. I'll back up. And so basically, there's this whole constellation of problems with urination that we call lower urinary tract symptoms, or LUTS, LUTS. And these are things. There's two categories of LUTS. There's the problems with storage, or the storage LUTS. So you can't store urine or you can't hold on to it. So that's things like having to go pee really frequently, having to go pee with a lot of urgency, so that the urge to urinate comes on very suddenly and it's very, very, very hard to defer, can sometimes lead to incontinence or leakage of urine if you can't get to a restroom in time. Things like having to wake up a lot at night to urinate, that's also called nocturia, or having pain with urination, or that's called dysuria. So those are the storage LUTs, and the uh, emptying LUTs are the other set where it's not a storage, not a problem with holding on to the urine, it's a problem with getting rid of it. So that's things like having a weak urinary stream, or having to strain to empty your bladder, or feeling like the urinary stream is stopping and starting, or feeling that it takes a long time to get the urine to come out, or feeling that the bladder is not fully empty once you've finished. And so overactive bladder typically tends to manifest as the storage LUTs, storage symptoms. So you have to go pee very frequently. There's a lot of urgency associated with it. Often, sometimes some leaking of urine or incontinence if you can't get to the bathroom in time. Oftentimes, these patients also wake up at night to urinate 2, 3, 4, 5, 6, 10 times, and it can be quite disruptive because uh, a lot of my patients, these symptoms can affect their social functioning. You can't go out to dinner with your friends because, you need to be, you always need to be like 30 seconds away from a bathroom. You can't, have a drink. You can't go traveling on a long car trip because you end up having to urinate midway through, and so it can be quite disabling. Um, Overactive bladder doesn't have an organic cause. There are some things that can mimic overactive bladder that are um, physical things like having a bladder infection, for example, or a bladder cancer, or having a foreign body like a stone in the bladder that's irritating it. Those can trigger the same symptoms, but those are not overactive bladder. Overactive bladder, by definition, is something without a clear alternative cause. And it's a condition that is idiopathic, which is a fancy way to say that we don't really know why it happens. We can't point to a single reason why it occurred. Oftentimes, it can come out of the blue. In a lot of patients, it's sort of this long-standing issue they've had for their whole lives or even years, and it can kind of gradually get slowly worse and worse. So yeah, the main things that will people will show up with when I end up diagnosing with them with overactive bladders is say, oh, I have to urinate every 30 to 45 minutes. I only get out a small amount, and that's because their bladders aren't really full. When I have to go right now. And I always, whenever I go anywhere, I'm looking for the closest bathroom, and I always know where the bathroom is.
So when you have those people that you would describe as having like the storage issues, um, what do you find are some of your go-to kind of treatment options?
Totally. So there's a set of guidelines from our national body, the Canadian Urologic Association. And so the first line treatments for these tend to be basically avoiding things that make it worse, or finding ways to mitigate the symptoms. Because there's no clear organic cause for this, unfortunately, there's very rarely a silver bullet that will absolutely fix things. Oftentimes, this is a chronic condition that involves learning how to mitigate it with behavioral strategies, and then basically other things layered on top in order to minimize the symptoms and make them manageable. Very rarely do my patients say things are completely back the way they were before. Oftentimes, people end up having to live with this to some degree or another, but the good news is there's a lot of things that we can do. So the first thing that we talk about is basically, it sounds simple, but finding out what causes the symptoms and then avoiding those things. So commonly there's dietary irritants that can irritate the bladder, things that we could think about like caffeine. We're all familiar with that. Alcohol. In some people, it's spicy food. Some people, it's things with a lot of acid in them, like carbonated beverages. Um, some people find that they can't have orange juice because it makes them have to urinate. Some people find that it's going out into the cold and the sudden change in temperature. For a lot of people, it's the symptoms are very, very strongly tied to their mental state. So when they're more stressed or sleep deprived, they find that their symptoms are worse. And that's something that is not surprising at all because the brain and the bladder have a very intimate connection. And so it's very, very common for mental state to be associated with urinary symptoms as well. So that's usually the first thing we talk about is like, okay, well, you need to take ownership of this as a patient and figure out what it is that makes it worse for you and try to avoid those things. as well, we often encourage the patients say, well, this overactive bladder that you have is making it so that, when your bladder gets to a certain point, say, a third full or half full, it feels that it's completely full and it tells your brain, all right, we need to go pee right now. So then you try to keep it below that level. So there's something called timed voiding where you have to go to the bathroom on a schedule, even though you may not necessarily feel like you have to, which is a bit of a funny concept for a lot of people, but intentionally keeping your bladder as empty as possible to avoid running into that sudden severe urge to urinate. Um, Pelvic floor physiotherapy is actually the one of the first line interventions for overactive bladder because there is a lot that can be done with pelvic floor relaxation or strengthening certain muscles. There's exercises that can be used to suppress the urge, breathing exercises and techniques. And so I actually try my best to recommend pelvic floor physiotherapy to patients as before even starting medications. Medications, and there are some available, tend to be the second thing I reach for if physiotherapy and behavioral modifications hasn't done the trick. And that's because these medications tend to either have a lot of side effects or they tend to be expensive and there tend to be things that you kind of have to take for a long time. Um, and so I think it's better to address the underlying cause and try to mitigate the symptoms with a combination of behavioral measures and physiotherapy before committing someone to a medication that they may have to take for the long term.
Mhm. And I've seen a lot of these people come with both at the same time, like just but they've also been told, like, I want you to use this medication while you try the physio. And like I mentioned, we'll get into this, what we actually do in the next episode, because I think that is a big misunderstanding is that people think all we do is strengthen people's pelvic floors. But you're right, there's a lot of education that goes with just to understand the relationship between the bladder and the brain and the pelvic floor. And it's just such a system that we don't think about. And so quite often just bringing it back to mindfulness around how it works, right? And I often use the analogy of around a tantruming toddler, and that if we give in to that toddler all the time, we know the ramifications of that they start, they learn to get what they want. And sometimes the bladder just becomes a priority to the brain. But yeah, so
I think that's a really great analogy.
yeah.
Um, and the analogy that I often give to my patients is, like if you have a lot of tension in your shoulders, if you're really stressed out at work, you can get headaches, and so you're from your head can hurt because your back and your neck are sore, and so similarly, your pelvic organs can malfunction and become painful when your pelvic floor is not in the right state, and I think a lot of us really have very little awareness of what our pelvic floor is doing. It's not an area of our body we normally think about. And so I think a lot of the awareness, uh, I've had, honestly, I have to say, more patients who are happy and have significant improvements in their symptoms from physiotherapy, more so than with medications. And, I've had people, I check up on them 3 to 6 months afterwards and say, you know what, like I tried the pills, they didn't really do much for me, but the pelvic floor physiotherapy really, really did make a significant change. So, you know, um, it was interesting because this is not an area that I spent a lot of time on. Like I said, I specialize a lot in cancer. And so coming to my own practice, I didn't really know what pelvic floor physiotherapy was, and I didn't really understand what you
We
guys
do.
talked about with patients and all the breadth of things that you could offer. Um, and so I would say, I'd say, well, I'm just following the guidelines here. Why don't you go see the pelvic floor physiotherapist? But then as I started to practice more, I started seeing these patients come back and having these incredible results, and being just so happy that they can come off their medications or they never need to take the medications in the first place. And so I've become a big believer.
Well, and it's good we're doing this episode, so it brings attention or brings the attention to other people too. I actually have a question that this is a very I want to address this because everyone comes in with the self-diagnosis of I have a small bladder. Can you speak to how often you actually would describe that anatomically people have a bladder that's too small? I always say it's more likely behaving small, but can you speak to that? Because people are adamant that they are born with a small bladder.
Yeah, that's fantastic you bring that up because I can only think of a few examples where someone physically has a small bladder, and it's usually if they've had some sort of prior treatment, like radiation or something that physically scars the bladder and decreases its capacity. The vast majority of people have a normal physical bladder capacity, but part of the whole OAB, overactive bladder spectrum, is that it feels small, like you said, and that's because basically the bladder is meant to be able to be relaxed and fill up to a certain point, at which point it signals the brain, hey, I'm full, it's time to empty. And if you ignore it, it can stretch a little bit more, and it sends a stronger signal and says, all right, now you really need to empty. And then eventually it says, all right, that's it. We're emptying right now. What happens in overactive bladder is that signaling, that normal relaxation, that's normal progression kind of gets messed up. And so the bladder will um, say, it'll have, say at about, a third of its full capacity or half of its full capacity, it'll say, oh, we're full to bursting and you got to empty right now, like right this very moment. And we don't really understand why that signaling changes, but it can and it does. And and so it's not so much a problem of the bladder itself being physically small, but more so that it's sending signals to the brain, thinking that it's full earlier than it actually is.
So that's kind of like a bit of a rundown on the storage issues. And like I said, we will follow this episode up with, I'm going to follow this up with another physio talking about in detail what we would do with people. But can you talk then about the emptying issues? Like just go into a little bit more detail about how that's different and what you would do differently with those people.
Sure, definitely. So the emptying issues tend to be due to something causing a blockage of the bladder. Um, the most common scenario is in men who have an enlarged prostate gland. Now, the prostate gland is a gland that's involved in the production of semen, and it sits right at the outlet and kind of wraps around the outlet of the bladder. It's frankly not a great design because the prostate over time in all men tends to slowly enlarge. And that's not in a cancerous way, but it just grows in a benign way. We call it benign prostatic hypertrophy, which is basically saying benign growth of the prostate gland. But as it grows, if you can imagine it wrapping around the outlet of the bladder, as it grows, it begins to compress the outlet of the bladder, and it can make it more difficult to urinate because it puts pressure and closes off the exit to the bladder and makes it more difficult for the urine to pass by. And so that's a completely separate problem. And for men who have that issue, it's usually managed with a combination of medications and potentially surgery to open up the prostate to allow the urine to leave easier. In other cases, if it's not the prostate enlargement, sometimes because of infection or trauma or injury, scar tissue can develop in the in the urethra, excuse me, and that can physically narrow the urethra, the inside diameter of the urethra, and cause blockage of the drainage pipe out of the bladder as well, which can also lead to difficulty emptying. And in other cases, it can be like a tumor or something like that causing a blockage. One other thing that can happen, and so I'll finish off that first thought by saying in women, a blockage is much less likely just because of the urethra in women is much shorter, and so there's less that can cause a blockage. That being said, in certain situations, women with pelvic organ prolapse or their organs shift or become loose, often because of prior pregnancies, that can sort of shift and kink the anatomy of the bladder and the urethra, leading to a difficulty peeing because of that. But that being said, those are the blockage issues, and sometimes in certain cases, the bladder muscle itself can become old or weak or lose its ability to squeeze. The bladder is made up of muscle that squeezes unconsciously. And as with age and or long-term insults like being blocked up for a long time, the bladder itself, the muscle can basically lose its ability to squeeze, much like someone's heart can lose the ability to squeeze and lead to something like heart failure. So the bladder can fail, and when that happens, it can't empty out as well because it can't squeeze to empty. And so in some cases, even though there's not even a blockage, patients will be unable to empty their bladders because of the bladder's inability to exert enough pressure to empty out. And I'm interested to ask, for you, Mel, do you see many of these patients with emptying issues? My impression is that it's not something that has as many solutions in pelvic floor physio, but I'm interested to see what your thoughts are on that.
I mean, if let's say someone presented to me before you, then I would like I only have certain things in my toolbox. So I'd be asking them kind of I'm obviously thinking of their age and everything, but stress plays a huge role here too. And I've actually had a few of your patients come over that are young. And so what I was going to say is if they come to me before you, I would absolutely be like, have you seen a urologist or anything to figure out like, is this actually you know, related to something like a blockage, as you mentioned, because I can't change a blockage. But a lot of times they're coming from someone like you first, where I know that you've ruled out a lot of that. So then my thought would be, okay, this is a behavioral thing or a habitual thing. I see a lot of young men that would also describe my stresses through the roof. Like I've had a few lately that would describe I'll never forget this one man that said when I go out on the boat with my friends, I cannot pee off the edge. They have to take me all the way to the shore and or I notice when I'm writing exams and I'm stressed that I have a hard time with my flow. I need to sit or things like that. But then right away, I'd be thinking of a muscle tone issue because it's the valve's too tight. They're having a hard time getting the pelvic floor valve to open. And, even if someone, like you said, had an actual, the bladder muscle is failing, I'd be like, they quite often have habits of the way they pee and they pressurize to let out pee. But then the pelvic floor muscle voluntarily contracts when you pressurize the abdomen too much. So just sometimes it's the way they pee. And so like helping them understand how to have control of the pelvic floor and recognizing the difference between tension and relaxation and then noticing when you pee, what do you do? Because quite often like, oh my gosh, I squeeze the muscles to pee and I'm trying to push pee out instead of let pee out. So a lot of times it's that kind of thing.
Yeah,
Yeah.
that's a really good point actually. And now that you mention it, I can think of several examples of patients I've had who have that issue, where you say you're presenting your symptoms sound like someone who's got a blockage of their urinary tract, but I've
Can't find
examined you
it.
up and down, and there's nothing. And I think a lot of that does come down to what we call functional issues, where we all have muscles that we can voluntarily squeeze and relax to that modulate the outflow of urine from the bladder. Those are called sphincter muscles, and you have to physically relax them in order to let the urine pass from the bladder to the outside. And I think this comes down to a lot of us not being really aware of our pelvic floors and understanding those muscles. And I think some people, either through maladapt behaviors that they have learned over time, or and never no one's ever really they've never realized and never corrected, or because of temporary situations like stress, carry a lot of muscle tension. The muscles are tensed in the pelvic floor, and that's where the urinary sphincter is in the pelvic floor. And so people will describe when they urinate, it's like it hurts and it's like you're peeing through a tiny little tube, or when you ejaculate, it's painful, and in for men with those problems, I'll do a digital rectal examination and I'll feel like, oh, your pelvic floor muscle tone is through the roof.
Mhm.
And often those people, you can really be benefited by learning how to relax those muscles. For first of all, gaining awareness of where those muscles actually are and how to control them, and then how to relax them. And that has helped people a lot as well.
I find that explaining to people that there's two ways to poop and pee. One, you create so much pressure, you blow past the pelvic floor valve, or two, you learn to let off the valve. And that's where a lot of people start realizing which way they do, because you're right, it's not an intentional thing quite often. Yeah.
Mhm. Yeah.
What about what about erectile dysfunction? So I know that can, be a bit of there's a lot that goes behind all of these terms, but overall, what can someone expect? Quite often, again, they'll come to their family doctor and maybe describe how this is affecting their life. They end up coming to see you. What's different about what you're looking at there?
Yeah. So with erectile dysfunction, or difficulty attaining an erection or maintaining an erection enough for sexual gratification, um, there's that's actually a quite a can of worms because there's a lot of things that goes
Mhm.
into it. Human sexuality is an extremely complicated topic, and uh, I, as a physician, deal with the medical side of things, the organic side of things. But there's before that even happens, there's a ton that happens, in the brain, and so. Um, and there's also a lot of different there's a lot of different expectations that people have, and so a lot of the time this actually takes a while to sort of unravel what people's expectations are.
Mhm.
um, some people will say, oh, I have a terrible erectile dysfunction, and the assumption is that, oh, you can't get an erection, you can't have intercourse, and they'll say, no, 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 I have intercourse, fine, but I used to be able to
Mm.
maintain an erection and go twice, but now I can only go once, and that to me is erectile dysfunction. So I think a big part of it is understanding what people's expectations are, um, and what their goals are. But and the other thing is that erections are very, very much a psychological phenomenon as well. And so if there's stress, or if there is fatigue as well, that's going to affect things. If there's problems in the relationship, or maybe not a ton of interest, or the relationship is, there's other issues in the relationship that can affect it as well. But from an organic standpoint, what I look for is physical problems with the penis, and potential signs that the blood flow to the area could be affected. And so the physiologic way erections work is, your brain sends a signal, and the blood vessels in your pelvis and your penis get the signal to relax and fill up with blood. That leads to an erection, and then the pressure inside of the penis basically cinches off the the blood flow out of the penis, and that's what keeps the blood in there. And that over time relaxes, the blood vessels constrict, and then the blood flows out again. So what I look for is, I take a history and see, like, are there any signs that there could be some sort of other illness that it may be affecting the condition of the blood vessels, because these are very small, very fine blood vessels. So things like diabetes or high blood pressure, or other, heart disease and stuff like that, point to perhaps maybe there's some systemic thing that's leading to the blood vessels not functioning properly. Um, or are there signs or symptoms of low testosterone? Because that can also affect your erectile function. Are there signs or symptoms of any nerve dysfunction? Has a person had previous spine issues, or surgery that might have disrupted the nerve supply to the penis? And are there other things that could be disrupting either the hormonal or the vascular or the neurological axes that are integral for erectile function? And then, if I'm ruling those things out, I ask about, the psychological things, that could be affecting function, because those kind of overrule all of the physical parts of it.
I think it's great. I mean, again, I know it's highly dependent on the patient, but I think two of the things that just stand out right now are just the important, a lot of times you'll hear that that could be the first sign of some heart disease, right? And so I think, hearing that is important for people to hear.
Hmm.
But also, too, I think we've just really started to learn so much more, because I think a certain generation is still hearing, well, you just need Viagra and then everything's fine. So I think it's good to just be hearing all the different things you're considering, because I do think that that's a generational thing where some of those people are coming in saying, oh my gosh, I just thought I needed a pill to fix everything. And so I think it's helpful for people to hear that it's a big topic
Hmm.
to think about different
Definitely.
areas. Pain. What a pain is a big one. So testicular pain, penile pain, scrotal pain. How often do you get that?
Quite often, unfortunately, there's um, there's quite a few people, unfortunately, who have chronic pain in their pelvic organs. And um, in women, that tends to go to more towards the gynecologist. So I don't see the women with chronic pain, but I do see the men with chronic pain, and which usually manifests as pain in the testicles, or in the scrotum. And oftentimes there's not a physical reason that I can identify why this pain is coming. Sometimes, you see, oh, there's um, like a vascular issue, or something that can be fixed, or some swelling in the testis that can be fixed. But a lot of the time, guys will show up and say, I have this pain. We do an examination, we get an ultrasound. I say, like, everything looks normal. I don't have a reason why this is hurting, but the patient is still having pain. And sometimes it's something that they say, you know what, it's annoying, but I can deal with it. But sometimes it's quite disabling. And some of my patients are say, I can't work, I can't have meaningful relationships with my partner because it's too sensitive. Um, and this is frankly, it's a tough thing to deal with. We don't have a ton of great solutions, or at least I don't have a ton of great solutions. I usually counsel people about same things like stress, which tends to correlate a lot with this. It is, if there's no organic cause, we do tend to classify it as a chronic pain syndrome, which um, is a tough thing to be diagnosed with, because that generally means that there's not anything that's going to fix it. And usually patients are unfortunately pretty disappointed to hear that, because they come to me looking for a solution. And I think it's unfortunate to have to tell them, like, hey, I don't have anything I can fix that will make this go away. We're going to have to focus on mitigation and learning to live with it. Um, and so I usually talk about things like avoiding stress, and figuring out what measures people can use to minimize their discomfort. I actually often send these patients for pelvic floor physiotherapy as well, because a decent amount of the time, the pain that they're feeling in their scrotum could be referred from pelvic floor dysfunction or pelvic floor muscle dysfunction. So I've had a couple patients who have come back and said, you know what, like, after I saw a pelvic floor physiotherapist, they identified that I carry an extraordinary amount of tension in my pelvic floor, and I had never realized before. And once I learned how to relax those muscles, the pain in my scrotum went away.
If I could give you a couple examples that I think stand out to me, because these are often coming from someone like yourself. And again, I think it always feels like a relief to us. We're like, okay, they've ruled out things. Now I can just try my tools, because there will come for us like a certain amount of questioning if they've come to us first. Like, I hope everything's been ruled out first, because my tools can't fix everything. So, a couple examples. I had this one man that came from a urologist with penile pain, progressing in nature. But as we started talking, he said, do you know what I think? Once I showed him what all the muscles of the pelvic floor looks like, and how the muscles around his anus are related to the muscles in the shaft of the penis, he said, you know what? A few years ago, I started developing this like intolerance to a certain type of food. I don't remember what it was, but I was having like chronic diarrhea. So I was holding my anus tight all day because I needed to go to work, but I was scared I would have an accident. And I can see now that when I tighten my anus, my penis kind of retracts. And so I'm like holding my penis tight all day. And so it was just a habit. He said the dietary issue was resolved. He's no longer having the diarrhea, but he's like, I still hold that muscle. And it was just learning that, oh my gosh, you don't have to hold that anymore. And he said it had resolved. Another man had a work-related injury. He has quite physical work, and after a heavy lift, noticed some pain in his under his testicles. He described like electrical pain. And in the end, I started getting him to lift different things and do different movements to notice how he does it. And he said, I contract my core so tight, and I can tell that that sends a lot of downward pressure, like a heaviness almost to my testicles. The way I lift sends downward pressure. And so we worked on lifting in a way where the testicles have support instead of feeling like they're getting bared down on all the time. But it's literally like a lot of habitual things and ways that people move. And I quite often use the example, next time you get out of the shower, notice you dry yourself the same way every time. Like, you probably have no idea, but you probably dry yourself the exact same way. And to change that is hard. It's doable, but it's the same as a lot of our other daily habits in the way we do things. So that's what I find for a lot of that pain. It can be um, like a movement preference that you have, or a muscle recruitment preference that you have. Yeah.
And that's why I send these patients to you, because these are things that I would never have thought of. These are things
No.
that I don't know about at all. And it's really wonderful to have someone else with a different skill set who can look at the problem in a different way, because oftentimes these patients are these patients are frustrated with us because, us in the medical field, because we don't really have any good solutions for them. And I feel, unhappy because I can't offer anything helpful, and people are obviously in pain. And so to have, a different perspective to offer can be quite a relief, and a really big tool for us as well.
And I think that this is like these like the specialties that deal with embarrassing issues. I think we're just a little behind because I always think like in a like an orthopedic setting, or like let's say this was we were talking about hips and knees here. Everyone knows their orthopedic surgeon doesn't do everything. Like there's no kind of pressure for them to provide the right exercises and to know what equipment to give these people. Like they learn in their training, send to the physio. I don't know if they really know what we do. They just know to send. And
Yeah.
I think that the male and female pelvic world, it used to be like all issues are kind of up to the specialist, or like it's a surgical issue. It used to quite often be, and now it literally is the same as kind of how we treat orthopedics. Is I have a completely different skills. I cannot not operate on someone's knee. I cannot provide medications. I don't know what the x-ray, like I can't order the x-ray, but I can work with completely different things. So I think like it's the same, right?
Mhm.
um
Absolutely.
what about another one that I see, I think a little bit more meaningful, this is my interpretation from my patients, a little more meaningful to the younger population quite often, is premature ejaculation. That's one that a lot of people describe as like a meaningful symptom. And would you say that's something like that just comes up as secondary with your patients, or do you get people coming in for that?
Um, a bit of both. I'll get patients who come in with another issue who say, "Oh, by the way, I have a lot of issues with premature ejaculation. It's really embarrassing to me." I'll get some patients who come in with a referral because they've gone to their family doctor or gone to a walk-in clinic, and it's clearly bothering them to the point where they feel the need to seek out a doctor to help them. Um, this, unfortunately, is an area where um, urologists don't have a ton to offer. The ejaculatory response is heavily, heavily modulated by what's going on in your head. And so much of it is tied up in stress levels. So I will back up and say that the what we do understand very well is the neurological pathways that are involved in erection and ejaculation. So um, in order to have it get an erection, you have to activate your brain has to activate the parasympathetic nervous system, which is the sympathetic and the parasympathetic nervous systems are the very old fight or flight or relax and eat parts of our brains, and so back when we were just much more simple and couldn't think as clearly, the parasympathetic system was activated when we were safe and feeling comfortable, and it was time to eat and go to the bathroom and relax, and it was security. um, and the sympathetic nervous system was when it was time to fight or to run or to do something and to be more active. And so those two systems are still preserved, and they affect a lot of what we do. So to maintain an erection, um, you have to be somewhat relaxed. You have to your brain has to think, all right, it's safe for me to engage in sexual intercourse. I'm not going to be attacked by a bear or have to run for my life anytime soon. So we can do this now. And so oftentimes, if you're stressed out, um, or you're not in a good relaxed headspace, it can be hard to get an erection. And then the sympathetic nervous system, which is the more active, fight or flight response, that is heavily involved in ejaculation. So when you um, when you ejaculate, that you sort of switch from the relaxed sort of erectile, like a parasympathetic system, to the sympathetic system to ejaculate. And so when you are heavily stimulated or anxious, that is stimulating your sympathetic nervous system, and that can lead to a faster ejaculation because you're already so ramped up in that standpoint. So what I often tell my patients, and generally these tend to be younger males who are maybe not as doesn't have don't have as much self-confidence or experience, and they feel a lot of pressure to perform in a way that society expects them to, or no, or perhaps media that they have consumed. They think the expectations are, and so they're stressed because they're like, oh no, like I don't want to, I don't want to come too fast, or I don't want to let down my partner. I don't want to seem like I don't know what I'm doing, and so a lot of those anxieties can build up, and that actually just makes the problem worse. So I usually tell these patients, look, I don't have much to offer you. Um, in some certain extreme cases, we can put patients on medications that are typically antidepressant type medications that can delay ejaculation. That's one of the side effects of those. Or you can, apply like some numbing anesthetic cream to the penis. But honestly, these tend to detract from satisfaction. And what I often do is I offer a referral to a sexual counselor who can oftentimes help people work through these issues, which are primarily cognitive issues. But very rarely is there something that I can offer to patients.
Isn't it funny how, like, the more you think about this, and I explain to people, like, when it's, they're having the storage issue, they're having the um, drain issue, they're having issues with erectile dysfunction. Like, don't you find yourself often saying, like, all of these are things we need to let go? Like, we need to be able to let go. They're parasympathetic. And
Hmm.
that's where quite often people are like, I don't let go of anything. I'm like, exactly. Like, this is never usually just an isolated thing, but they
Hmm.
start to realize, oh my gosh, I hear this message all the time. And I do see more and more of that. And people are like, oh, I just need
Hmm.
to learn to let go. Yeah, it'll probably help a lot of different things in
Yeah,
your life, right?
definitely. There's often like a light bulb. You can see the light bulb go on in people when you say like this is probably tied to your stress, and they said, oh, because I don't think people have realized that the like stress and your mental state can play such a role in, your the functioning of your pelvic organs or your urination. I mean, I don't think for people who don't deal with this every day, it's an association that they don't often make. I'm actually interested, like, is premature ejaculation something that you can help people with?
Yeah, and that's what I'm going to cover a little bit more in the next episode, so I don't want to give it all away, but absolutely, I think quite often it's just a matter, we do so much education, and it's not always physical exams that we do, but quite I have lots of different models or pictures or things I bring up on the computer just to help people understand, because I think it's literally something that we feel we have no control over. People feel they have no control over peeing and bowel movements and sexual function. So I think the biggest thing is just understanding. And all physios have different ways that they treat, but I can speak for myself and say I rely heavily on education to start with, and a lot of mindfulness, like getting them to go home and notice things. Like before you try to change everything, just notice habits that you have, because and then starting to notice, like, oh my gosh, I have a habit that maybe is not helpful for that. But I think, like you mentioned, is for example, with premature ejaculation, is there starts to be kind of like a stress behind what's going to happen. And so once you give them some element of control or something to think about, then sometimes that helps. But yes, we'll go into it in more detail in the next episode, because I think, again, something else that people will never tie a physio to, right? And
Hmm.
usually, like, this is not something that needs pelvic floor strengthening per se, but most of these clients or patients go online, they Google things, and it seems like their takeaway is always Kegels. They always come saying, I've been doing my Kegels, I've been doing my Kegels. I'm great, I'm glad you've thought about it, but maybe we need the opposite, learn to kind of let go. Yeah,
Yeah,
exactly. For
yeah.
some reason, the pelvic floor has been kind of married to, like, we need more strength, we need more tension, and rarely is that something that people need. Yeah.
Yeah, I get that a lot actually. I'm saying like I'm gonna refer you to a pelvic floor physiotherapist. Like, no, 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 oh, I already do
Yeah.
Kegels. I learned how to do them online. I'm like, no, 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 like that's it's more than just that.
Yeah.
There wouldn't be an entire profession based around just one exercise. So trust me, they can do a lot more for you than just Kegels. And I think in your case, you should do fewer Kegels.
Exactly. And so that's just a big misconception out there. But yes, there are, and I think it's great too that this is, to me, this is a new thing that everybody's learning in their training, is like the basically the biopsychosocial approach to thinking about the mental health too, because I think certain generations have that all separated. My mental health and physical health are completely separate, and I just need a medication, or I just need the urologist to do a procedure so that I have better ejaculation, I think is what I'm so glad that we're covering that that's not the case.
Hmm.
Um, So another big topic that you've already touched on, but prostate related issues, because this is huge when it comes to men's health. So again, you've already touched on this, but especially with the issues with urination and letting out urination, this is quite often where it shows up. But maybe will you speak a little bit to is there what's the certain age that maybe family doctors are starting to think about the prostate a little bit more? At what point are they referred to you? We haven't talked about anything surgical yet. So I think this is probably the biggest thing that would make a man have a surgical intervention as a prostate related issue. So just could you speak to that a little bit?
Yeah, totally. So it's kind of a, well, it's kind of a big thing to
It's a
unpack.
big
So
topic. Yeah.
yeah, so the issues with an enlarged prostate tend to show up in middle age, generally 60s, 70s, some people as early as the 40s or 50s. It's largely a genetic thing. I find that patients who show up earlier had dads and grandpas and uncles who had issues that needed addressing earlier as well. We don't really know why. And again, we're talking strictly about patients with benign enlargement of the prostate here. Um, and this, like we said, generally manifests as having a weak urinary stream, like, it just dribbles out, or I can't get the bladder empty. I can still feel that there's more in there, but I can't. And as a result, the bladder stays partially full after they finish urinating. So they'll pee from 90% full down to 50% full, and then it fills up again to 90% much more quickly. So they say, I have to go pee really often. Oftentimes, chronically being blocked can actually lead to symptoms of overactive bladder symptoms as well, because they'll say I have to wake up a bunch at night, and when I have to go, it's really urgent and frequent, and so it can be sometimes a bit tricky to unravel whether this is an issue with the blockage causing the bladder to have to go pee frequently because it doesn't empty out enough, or if this is primarily an issue with the bladder being overactive and blockage isn't a concern. And that's what I do, and where I specialize in is sort of deciphering which of the two it is, or if it's a bit of both, which one is more pressing to address first. Um, and if we feel like it's an obstructive problem in a large prostate, typically we start off by uh, my first suggestion is usually trying medications. There's medications that can physically shrink the prostate, and there's medications that can sort of relax the muscles, the smooth muscles at the out of the bladder. These are the muscles that we don't have physical control over, but can be influenced by certain pharmacologic agents. And for the majority of men, medications are enough. But at a certain point, medications may not be enough, or patients may find that they can't tolerate the medications because of the side effects, or they just don't like taking medications. And then we can talk often about surgery.
Can I ask you
Um,
a quick, sorry to
yeah,
interrupt.
of
Can I ask you a
course.
quick
Yeah,
question about the medication?
yeah.
Would you want these men, because like for example, estrogen is something that women at a certain age will take and they're supposed to take kind of forever.
Mhm.
What about the medications for their prostate? If would you want them to be taking that indefinitely, or is it more for a certain amount of time?
So generally, indefinitely. Now there's a bit of wiggle room there. Sometimes um, one of the most common medications is called tamsulosin, and this is a medication that works by relaxing the smooth muscles at the outlet of the bladder. That one you kind of have to take indefinitely, if you don't take it, then the muscles sort of tighten up again, and then you lose the effect. There's another medication called finasteride, or its cousin dutasteride, which actually physically shrink the prostate, and so those medications, if they're effective, you can sometimes you can take them in combination with tamsulosin, or if the combination is effective, you can withdraw the tamsulosin and see. But generally, these medications end up being long term, and for some people, they don't want to be on medications anymore, and so that would be an indication to proceed with a surgical intervention. And then from there, we sort of venture into the wide world of surgeries for bladder outlet obstruction, or BPH, of which there are many with many different indications. There's types that are covered by the government. There's types that are private pay. This is a very common problem, and of course, the medical pharma companies are keen to get involved. Um, Suffice to say that most of these treatments involve removing or destroying part of the prostate tissue to basically widen out the channel of the urine. So it's hard to do without visual aids here, but basically the urethra runs through the inside of the prostate, so the channel through the inside of the prostate. Um, and most of the treatments involve basically widening that channel by coring out the prostate from the inside. And once that heals over, basically you just have a wider channel out of the bladder. And it's very effective. These treatments are very effective for people, and often they're very satisfied, but um, it is a surgical intervention. It is irreversible, and there are certain risks associated with any surgery. So generally, we try to get by with medical therapy first, unless the person says, you know what, I'd rather have a surgery than take these pills.
What's your thought on, so would you say, I have actually had a couple of your patients lately. One of them said, I had a procedure like you just listed or you just mentioned, and I'm just having a little bit of incontinence since. So Dr. Ho sent me over. Another one had to have a radical prostatectomy and
Hmm.
no more internal sphincter. So
Yeah.
he has to rely heavily on his pelvic floor sphincter. So, but both of them, um, would you say it was, again, you can't, I'm not, you don't know who they are, but would you say it's because they had issues after, or do you find yourself also thinking about physio preemptively, like before someone has surgery? And can you talk a little bit about why? Because I think people don't understand.
Hmm.
Why would I, if I'm having a surgery, why do I need physio?
Great question. Two very different examples, because surgery on the prostate for an enlarged prostate is very different in terms of how it's done and what the outcomes are compared to surgery for prostate cancer. So we'll talk about the first one. Incontinence after a surgery for enlargement of the prostate can happen, but it's rare. Um, and so part of what, if the patient comes to me after says, hey, I couldn't pee very well before you did this, and now you do it, now I leak. For me, it's up to me to figure out, is this an issue where the muscular sphincter is weak or damaged, and so now that the blockage has been removed, the patient can't hold on to their urine? Or is it an issue where they perhaps had some overactive bladder elements as well, and now the bladder is squeezing a lot, but they don't have that prostate in the way to keep them from leaking, and so they leak? So for me, it's figuring out whether this incontinence is what we call stress incontinence, where you don't have the muscular strength to hold the urine back, or is it urge incontinence, which is typically associated with overactive bladder, where you have a sudden urge to urinate and you can't stop it. Um, and if it is stress incontinence, what is often the case is because guys with large prostates have had this blockage that they have uh, had to deal with for such a long time. They aren't in the habit of using their urethral sphincter, the voluntary sphincter they can control, because there's just a blockage holding the urine back, and they actually have to push to get the urine out to begin with. And then so you remove the blockage, and then all of a sudden this muscle hasn't been getting a lot of use, and then they rely on it again because the prostate has been the blockage has been removed, and so oftentimes that muscle can atrophy or become a bit weak, and in that case I would definitely send them to you. If I find out that they have some overactive bladder issues as well that have been unmasked by removing the prostate tissue, then I send them to you as well, because both of those issues can be addressed by pelvic floor physiotherapy. Um, in terms of a radical prostatectomy, so this is for patients who have had prostate cancer. Surgery for this is very, very different than surgery for benign prostate. In benign prostate, you typically leave a large portion of the prostate gland inside, but you sort of core out the prostate, or you remove some tissue from the inside. In a radical prostatectomy, surgery is done through an open incision, or sometimes through robotic surgery, but the entire prostate is in its entirety is removed. So you physically cut the prostate off of the bladder and cut the prostate off of the urethra, and then you have to physically rejoin the prostate you have to physically rejoin the bladder to the urethra. Now, this is damaging to the urethral sphincter, because the urethral sphincter that men can control is right at the edge of the prostate. And so you actually physically have to peel the muscle fibers of the sphincter away from the prostate in order to remove it. And and then you put some stitches in and bring things in, and there's a bunch of inflammation, and it changes the angles and the anatomy of the urinary tract as well. So there's often almost universally some degree of incontinence after a radical prostatectomy, and we tell all of our patients about that. And um, part of the recovery from that is learning how to strengthen those sphincter muscles, because they've been damaged, and so how to regenerate them and how to strengthen them. Um, and patients will gradually gain their continence back. And oftentimes, I universally send these patients to a pelvic floor physiotherapist afterwards to review and to sort of undergo some counseling and treatment on how to strengthen that muscle again after it's been damaged in surgery. Um, and more, we are realizing that prehabilitation, or
Mhm.
having these patients strengthen that muscle before they go in for surgery, can also be helpful and speed the recovery as well. And I have to admit, that's something that I am still trying to remember to do, because oftentimes I book a patient for surgery and then within a few weeks they're in the operating room, so they don't necessarily have the time. Um, but you know, and also, you guys are busy too, and so sometimes the wait lists don't quite add up. But I'm trying to get better at uh, sending them early, even before they've been committed to surgery, so that you could potentially get some sessions in. Oftentimes as well, like there's some online resources that I can point them towards on like how to and this is a case where Kegel exercises are actually helpful, but like how to perform a Kegel exercise, and what it should feel like and what it should look like. And at the very least, I try to get them to look at that and do some practice beforehand to strengthen those muscles, with the hope that the better condition they are to begin with, the after I'm done, causing damage, the better condition they'll be in afterwards.
Totally. And I think that you're right, like the strengthening is important. And I also say like most of those men that come in after any type of surgery down in their private areas, they don't even like to talk about it half the time. But I think like think about the procedure that you just had and how does it make you feel? Does it make you feel relaxed or does it make you feel tense? And so like a lot of them are walking around with a lot of tension around like what am I left with? What happened? Something was in there. And they do hold a lot of tension and sometimes have a hard time letting go as well.
Mm.
So um I'm going to do a whole nother episode on like prostate specific information too, because I have a couple thoughts there. One is just, you know, to come after this episode, we've got like an Okanagan based website that's going to share a lot of this information to people for obviously no cost so that they can start to learn about some of this before they come to our appointments or while they wait for their surgery. And I hope this is a resource along with some of these other ones, Matt, that you feel like you can recommend to exactly like lighten your load. And when you say it's hard to get into us, sometimes I think, oh, that's too bad that they can't have this access to information before their surgery, but we're
Mm.
working on it.
Yeah.
Another thought, before we tie up here, I'm mindful of your time, is just like mentioning some of the barriers to physio. So you mentioned even just, remembering in your short amount of time all the things that you want to tell your patients. I think just also too, like I don't know a lot of the things you do in your appointments, and you don't know a lot of the things that we do in our appointments. So I think that this is helpful just to learn a little bit more about what's happening, but also to the cost. I think you can't not mention that. And I think it's hard for people because yes, the healthcare system and indirectly through taxes we pay to come see someone like you, but people have to pay out of pocket unless they have extended medical benefits to come see us. And isn't that too bad that things like surgeries are quote unquote free, whereas coming to see, and a lot of the treatments you mentioned, like before surgical intervention, the guidelines suggest physio, but it's too bad that it's that part's not covered, whereas surgical interventions are covered.
Yeah,
Isn't
I
that so
agree.
backwards?
It is, and yeah, it's problematic because I think more and more so, uh, we're realizing that physiotherapy is not just an adjunct; it is part of the core treatment algorithm, and so it's hard to do the job properly without it. And so I really do think it should be one of the core services, um, but
But yeah,
it's that's it's tough because adding that would be great, but the realities are tough. But I try my best to impress upon the patients, like, this is important. This is a critical part of your treatment. And um, generally it's not like you're going to be seeing them for dozens of sessions, right? Like, what's the average number? Like
Yeah,
three,
I
four?
often tell people sometimes I see them once and I'm very mindful when they come in. I mean, I think four is a lot. I
Mm,
mean, of course, I see some people more than that, but
mhm.
when I book people ahead, I'm thinking two or three-ish. I mean, obviously there's outliers there, but
Yep.
exactly, it's not like coming every week for the rest of your life by any stretch of the imagination.
Hmm.
Yeah.
And so I usually try to tell them, like, look, yes, you have to pay out of pocket, but trust me, like, this issue will get better and this will help a lot, and it will not be a significant time commitment. And the financial commitment is, for some people, hard, a barrier, but for most people not.
So, if we keep in mind that the reason we're recording this is because we hope that patients that have these symptoms listen and have a better idea, maybe before they come to see you, of what to expect. They start to think about some of their options, and maybe they have an idea of what a physio might do. We know I'm going to record an episode after that goes into more detail, but is there anything else that if your patients were listening to this, Matt, that you'd want them to know?
I'm trying to
I
think about
know.
this because I think we've
Yeah.
probably gone through a lot. I mean, I think that um, the bottom line is that the more we learn about healthcare and how to treat people, um, the more we're realizing that an integrated approach, a multidisciplinary approach is incredibly important. And you know the the so-called allied health are, I think, more and more central to a lot of things that we're doing, because Western medicine does not have the answer to everything, not by a long stretch. And so I think people often are kind of like a little bit confused when I'm say, like, the core of your treatment is going to be physiotherapy. And I think the message is that that shouldn't be a surprise, and that there are, depending on the problem, there are certain professionals who are the best, who are going to be the provide like who are going to give you the best outcomes. And sometimes that's a physiotherapist, sometimes that's a massage therapist, sometimes that's a counselor, sometimes it's a surgeon. And I think your entry point to that may be one of these particular professionals, but we're all part of the same team. And sometimes it takes multiple people providing solutions from different perspectives in order to get someone where they need to be.
And I think just as you were talking, I was thinking too, just along the parallel I made with an orthopedic surgeon, is that if you have knee pain, you rarely go straight to the surgeon first. Like you probably might not even think of going to the family doctor first, but you have options and surgery could be an option. But usually we exhaust things like massage and rest and physio and things like that before. And a physio knows when you need to see a surgeon. Like we kind of know what's out of our scope of practice and what we can't do. And it's the same with this type of issue. And I think given that it takes a long time to come see someone like yourself, I hope we can provide some ideas of things you can do while you're waiting. And maybe you don't need to get that far to that specialist. Maybe your symptoms are resolved with some of these more conservative things before you get there. But we also know when you need to see someone like yourself. And so it doesn't mean you have to choose one or the other, but maybe being thoughtful on where you start. Yeah.
Absolutely. Yeah.
So thank you so much for your time, Matt. I appreciate it and I appreciate all you do and just your holistic way of thinking of things. So thank you so much.
Thanks for having me on.